Okay, Bill Tunnicliffe.
Thank you, Sir David, and thank you, Dean, for a really inspiring presentation. I just can't believe that it's happened and it's almost ready to run. I guess my view and my challenge is, isn't this what we should be doing for all of our patients, regardless of disability? And can we not adapt and borrow your style, the way you've done this, to actually make a guide that works for all of our patients, not just those who are disabled? And I don't know, Anna, that's quite a challenge, but I wonder whether you'd like to reply to that.
Yeah, absolutely. And I think it's crucial. It's one size doesn't fit all. So yes, it's about how we can provide accessibility in the widest way. So we are doing pockets of work, and maybe we can bring some of those back to the board as they roll out. So say, for example, we have a hospital youth forum. So we're working with the youth forum. It started off as a project about signage, but essentially it's about accessibility. So from before you even step into the hospital, what's it look like? What's it going to be like when I get in there? How can I fully prepare? We've started to kind of work that way throughout the pandemic, to be honest, preparing people who were quite nervous. We started off in children's, people coming in for some surgery that have restarted, and how can we do this in a different way, more visual, using animation. So we are starting to do that, but yes, pan everybody, but maybe not one thing, lots of different things, so people can choose something that means the most to them, and crucially working with stakeholders and groups to develop that together.
We can I just add very briefly to that? So we have, as part of our offer, we haven't done it for Worcestershire just yet, because we only developed it just after we started the project with yourselves, but we've just started implementing what we're calling virtual tour access guides. And these are effectively 360 degrees moving photography throughout all your departments and wards. So the idea is effectively a route plan taking you from the car park to where you need to go. And users can stop it along the way and have a look at anything they want. There are accessibility overlays, so you can have all that detailed accessibility information on them, but you can also turn that off. So that might be something that I could perhaps send as an example to show you what we've done. And if you think that might help you, you can always have a chat with us on that, and we can see how we could perhaps implement it at the Trust.
That's amazing. Thank you.
Yeah, thanks. Vicky.
Just to say thank you to Dean. I think there's so much rich information and potential for improving experience. It's fantastic, Dean. Thank you. And I know you kindly distilled your 37 slides down to the 10. Which is, it would have taken too much time, but there's lots of information there. So perhaps if you can share, share the link that you previously sent yesterday with all board members, so they can view that at their leisure. But a big thank you from me.
Thank you.
Okay, I think I've covered. Anyone shout up that I've missed? I think I've missed everybody. So thanks for that, Dean and Anna. That was just fantastic. And as I said earlier, this whole issue about patient experience is a matter of detail, getting those small details absolutely right. And you've shown us the potential there is out there for expanding our offer in terms of identifying the patient experience and going through. And thanks, Anna, for the fantastic work you've done on this. It is just brilliant. Thanks to Mark Yates, who actually received this issue, and then I think you described it as a no-brainer, Mark, and then drove the initial conversation forward. There are lots of no-brainer issues that still don't get done. So thanks for doing that, Mark, Anna, and Dean for the contribution. We really look forward to seeing the two guides that you described, Dean, so that we can start to take action to not just explain what the position is to people, but also to improve it. And I think we would be really interested to see ways in which we could extend this offer to a broader range of our patients, to be part of the way we do things around here. I think would be incredibly important. So thanks very much for your efforts, Dean, and thanks very much, Anna, for your drive and determination. Thank you. Okay, let's move on then. Are there any other items of business that people want to put on the agenda before we end? No? Good. Minutes of the previous meeting. Are they a reasonable reflection of our conversations? Yes, people happy
Yes,
with that?
yeah.
Good. Your hand's still up, Bill, by the way, just in case I...
Thank you.
Okay. Log. Kamara.
Thank you, Chairman. There are no outstanding actions. There's just two which are due in the new year, 2020. Sorry, it should be 2021 on the action list. Can we just note that as a result of last month's patient story on iPads and use in neonatal, that we have Richard Haynes has progressed that and has sourced the stands that we talked about at the meeting. So that was very quick turnaround, and it's obviously reaping benefits for the patients within maternity and neonatal. I think it's worth noting that's been done.
Yeah, very good. Thanks, Richard. Thanks, Richard, for that. Okay. Anything else on the action log? No. Okay, some chairman's remarks, and I want to talk about some people issues around. First of all, congratulations to Bill Tunnicliffe. He's been appointed for another 4 years as a non-executive director of the trusts. Congratulations, Bill. You could at least smile when I say it. It's a good thing. You continue to make a contribution. Secondly, this is the final meeting of Steve. Where are you, Steve? You are here, aren't you? Steve's been a stalwart non-executive director of this organisation for some time. He took on the role of the chair of the audit committee, which is never easy, but also given the experience and the environment that we've been working in over the last few years, has done an absolutely remarkable job to take us from where we were to hopefully getting to a position where we're within sight of being able to sort out the long-standing issues around finance for the organisation. Thanks, Steve, and I hope you enjoy your new life in London, and all our wishes for a successful time there. So thanks very much, Steve, for that. And then Kamara, this is your last, Kamara Sharp, our company secretary. It's her last board meeting. I'm sure we'll have the opportunity to say goodbye to her in other circumstances, but just to put on record the board's views about the massive contribution that you've made to this board over the last period. From a personal perspective, you've certainly both kept us safe as an organisation, made sure that we make decisions in the right kinds of ways, and that the processes and systems that underpin all of that are right, and also made sure that we did the right thing when we needed to. A constant resource for us all, a great experience and advice, and again, someone who has seen us through very difficult periods as a board into places where I think now where we can make real progress. So thank you, Kamara, very much. I described her when she told me she was leaving as Mrs. Worcestershire Acute Hospitals NHS Trust. I associate the trust particularly with her, and because not only does she do the kind of work that I just described in an exemplary way, she has the kind of values and patient focus and commitment to patient care that I think is a real kind of inspiration to all of us who are working in the board. So thank you very much for that, Kamara. And then finally, we've appointed two new non-executive directors, a non-executive director and a non-executive associate director. I'm afraid because of the bureaucracy involved of NHS improvement, I can't announce them publicly at the moment, but I will do at the earliest opportunity. So we will see some new faces on the board who I think will be a massive contribution to taking us to our next phase. Okay, thank you. Let's now move on to strategy and the winter plan. Chief Operating Officer, Mr. Brennan.
Thanks, Chairman. What you've got in front of you is a summary of the winter plan, and it's a slide deck overview that picks out the key messages. I think the points I would bring out is that, first of all, we had to do a considerable amount of work in assessing where we felt we would be this winter in modelling, due to a combination of what we saw in the first wave of COVID. And when we did this plan, we were in the dark about the second wave, as it hadn't materialised then. This was developed in August and September when we did the modelling work. So we had to think through what we felt the winter would look like. And then, in addition, we were having to work through the beginning of the announcement around the phase 3 of the pandemic and how to return elective work following the first wave of the COVID outbreak. So the slides give an indication on page 15 and 16 of the pack of the modelling work that we've done and where we concentrated our analysis work. And then page 17 of the pack just gives the methodology that we used, and then page 18 shows you the analysis work that we did. And what that shows is it's a look at the general and acute beds across the trust, how many beds we modelled would be taken up by COVID pathways, and then undertake a range of scenarios to see whether we felt that we would have a gap or not. And you can see from the outcome of that, our assessment was that we would probably have around about 126 beds that would be tied up over the winter period as a consequence of a second COVID wave. And at the point of doing the modelling work, it was the information that we had from the national position was that we would be able to maintain access to the independent sector, which, as board members are aware, that closes in this month. So we've had to create our own equivalent of a kind of super clean or purple pathway. And that work has taken an additional 48 beds out of the G&A allocation. So we would add that to our assessment of 126, which would give us around about 170 beds dedicated to COVID pathways. Just so board members are fully aware, as we are today, then the number of our G&A beds that are dedicated to COVID pathways is 260, including those purple beds. So although we did a lot of detailed modelling work, you can see that the number of beds, general and acute beds that are taken up by COVID pathways are significantly greater than we modelled, and that is proving a huge challenge now on a day-to-day basis. The next slides, 19 and 20, outline the main projects that have been developed this year for trying to address any shortfall in capacity, and they mainly fall into kind of three areas. One is the more kind of system-wide strategic, and that includes the Think 111 project, which, as you, again, board colleagues are aware, we were the pilot, the first runner in the Midlands region, and certainly the view that we've had back from colleagues in the regional team and the national team is that the way that the system has worked together to implement that 111 project and how it's been overseen is viewed as excellent and being used for other trusts, or other systems across the Midlands region. We're the first cut of the data analysis to see what's happened since we've been live on the project, and we're due to receive that next week. What I would say is the general view from colleagues working at within the emergency departments is that the 111 project has probably led to an increase in presentation in the EDs, not a decrease. And I don't think that would necessarily be a surprise to colleagues, as we did highlight that as a significant risk in going forward with the project. The other area has really been around the community, with the implementation after an initial pilot of a county-wide community 2-hour response, the continued development of neighbourhood teams around prevention, and a joint programme between the Health and Care Trust, the CCG, and ourselves on increasing community-based IV therapy so that we minimise the number of patients who were simply in an acute hospital bed for IV. So we extended the OPAT team with both additional medical and nursing resource. And then within the hospital, colleagues will be aware that we have developed the acute medical unit proposal and implemented that in full at the Alexander Hospital, and that is working exceptionally well. What we've seen since we implemented that model is that length of stay at the Alex putting in the AMU was running around 6.4 days as the average length of stay, and now it does oscillate slightly, but it's running between a low point of 4.6 and a high of 5.4, and averaging about 4.9. So we've seen that model deliver a significant reduction in length of stay at the Alex Hospital. We have not yet progressed that out on the Worcester site due to a combination of the number of beds on this site that has actually been passed over for the COVID pathway that I referred to earlier, and also the work that we're doing on the major capital development for the urgent care centre that is being worked up. We have, however, developed the proposals to enhance one component of that, which is the acute emergency centre, the ambulatory unit, and that will become operational on the Worcester site on the 24th of December, and that will double the capacity of the previous AEC that was in place prior to COVID, and it being redesignated as a red COVID respiratory area. And then the other main components of the work internally were around the Home First programme and the delivery of Red to Green. You'll then see on slide 22, we have identified there the bed day deficit, and if you, just for those who pick things up, you'll see on the chart I referred to on 18, we were showing the bed day deficit was just under 24,000. That was an annual estimate on the modelling, and the chart, which starts off with a 13,000 bed day deficit on page 22, is a proportion of that for 5 months of the year. You can then see against each of the main schemes the assessed impact on bed days, And if all of those schemes delivered at 100%, then the deficit turns into a surplus that gives us some headroom. I think it's important that we bear in mind that last year the work that was done and then the actual delivery identified that the success of last year's winter schemes was running at about 24% of their programme delivery, and this chart on page 22 is showing the impact of 100% delivery. The biggest deliverer in last winter that achieved the most success was the AEC, where we did increase the capacity slightly but extended the hours of opening. And as I said, that will be coming back online on the 24th of December with double the capacity. Now, that was not modelled into the estimates that are shown on page 22, as that wasn't, we weren't able to confirm we were able to deliver that at that point in time. And then the final sections of the slides just set out the monitoring arrangements via the A&E delivery board, and then finally just identifying that we will be implementing the single health early warning database across the system, which will give us real-time data from West Midlands Ambulance Service, our own discharges, admissions and waiting times in A&E, and then the status of community beds and NHS 111 at any one time. So that's a kind of brief overview of the winter plan. I think that the positives are that we have seen significant joint working with colleagues across the system, and that continues. I think we've seen improvements through the Home First programme and a much better functioning now of the Onward Care team, which is delivering the AEC development will have a significant impact. And through the Home First programme, what we've actually seen is a significant improvement in the number of discharges per day. You board members will recur that the weekend to weekday ratio was running at less than 50%, and that the overall discharges per day were running at around about 120 last year. At the moment, the average since November is 150 discharges per day, Monday to Friday, and we're seeing an average of about 120 discharges on a Saturday and 80 discharges on a Sunday. So that is an improvement on last year. I think on the downside, I've referred to 111, indicating that we do need the clear data, but the initial indications are that has probably increased activity into the hospital. I don't think at this stage the community 2-hour response is delivering the changes that we were looking for when we developed the plan, and clearly the level of our general and acute beds that are dedicated to COVID-related pathways are significantly above what was forecast between the first and second waves. Thank you, Chairman.
Okay, thank you. Right. This has been considered by the Finance and Performance Committee. Any observations you want to make at this moment, Richard, about what we've just heard?
Well, first, a positive one. I think the preparation has been much better than last year, and so was the system working on this. And I also feel that the detailed analysis work, and that's what we discussed in the committee, has been done in a better way. But clearly, we were also concerned about two things, the assumptions, and I think Paul talked about our assumptions around the number of beds dedicated to COVID, which is significantly more right now than it was in the planning stage. And in general, and Paul talked about the success rate of the measures last year of 24%. If you look at the table on page 22, it assumes 100%. So the concern was around what do we do? What is the contingency that we've got? What are the measures if the assumptions are not realizing the way we anticipated? And I think that's the main concern, Sir David.
Okay, thank you. Could I just ask Paul just a couple of questions about that diagram on page 22? These said that what are described as waterfall diagrams, aren't they? It's because it's slightly missed off on mine. Obviously, the biggest impact is going to be the 6,840, which says continued reduction in what? What is it?
Inpatient length of stay.
Okay, and then if you add to that, what's your judgment on the savings from the opening of the AEC?
So the AEC last year achieved round about 3,000 bed days equivalent. And as I said, that when it opens again on the 24th of December, it will be functioning at double the capacity that it did last year. So what we're looking for there is working with YMAS to increase the number of patients that are not passing through ED and are going direct into the ambulatory facility. And then in addition to that, we've had CCG colleagues support financially to extend the surgical clinical decision unit as well, so that we can increase the capacity and opening period for that unit. So in terms of Richard's comments about contingency, what was not included in the plan that is now in place or coming online is the extended AEC capacity, the extended surgical clinical decision unit. But I still think that given the number of beds that are related to the COVID pathways are so significant, that that's the big risk area.
So what is the view about the COVID stuff? Because there's a debate at the moment about whether hospital activity is going down or not.
No.
Is it?
Or no. So the number of patients, new patients presenting, has been running at double figures for probably about 4 weeks now. The number of positive patients, for example, in our beds today is 103, and that is the highest number since the 25th, I think, 26th of April, which was, still well within the first wave of the pandemic. So we are not yet seeing any slowdown, and if anything, we're seeing increased presentations. The only reason number of positive patients
Sorry, Paul, I've lost you.
Sorry. Can you hear me now?
I can hear you now.
Yeah, so I don't know what that was. So the only reason that the number of positive patients is kind of maintaining around that 100 level is due to the number of discharges that we're seeing of positive patients each day. So we're tending to see the number of positive patients, so that 103 that I quoted today, going up by about 2 or 3 per day. But the number of new presentations is averaging round about 12 a day. And then there are the discharges and, unfortunately, some deaths that are keeping that overall number low.
So is your assumption then that this 240 figure, 260 figure that you talked about, is it your view that's going to carry on through January and February?
Well, what we're seeing in the community, so the presentation per 100,000 has dropped significantly for Worcestershire over the last couple of weeks, from over 260 to I think the last figure I saw was 97. And the public health view, talking to the public health team yesterday, was that that should translate into impact on the hospital in about 2 to 3 weeks' time. Right. So I don't see any reduction in the number of beds that are diverted to COVID pathways, I would say, until mid-January at best. I don't know if Mike would agree with that, but I can't see any slowdown before kind of mid to late January.
Okay, thanks for that, Paul. Can I ask, Bill Tunnicliffe's wants to say something.
I said it was really to explore the COVID situation. My view is that we are in for an even more difficult time with the Christmas period with family mixings, and that anticipating any slowdown in January, I think we may be disappointed in that. I think we may well see an upswing in the latter halves of January as a consequence of those events. It was really to ask, Paul, first of all, to say thank you and repeat those comments of what a great job has been done this year compared to previous years. It's just really feeding in the COVID data into your modelling. What does our bed day gap look like with the sorts of numbers that you are now projecting for COVID?
In a full year, so the 23,000 that is shown on page 18, the kind of shortfall of around 23,000. If we continue where we are at this level, then that 23,000 is likely to be in the region of 40.
So, as a consequence of that, are there any other actions that the system should consider taking to mitigate that? And I'm thinking particularly about public health messages around bending rules at Christmas. I'm deeply concerned that we are in for a very, very difficult January.
Yeah, I mean, I'd agree, Bill. I mean, I think we're all fearful of the consequence of those 3-5 days. I think they're being labelled as now. The public health team are trying to get messages out, as if the district councils, about maintaining social distance. I don't think there's any way the vaccine is going to help us this side of Christmas. That'll be well into the spring, in my view. Others may be more hopeful, but I can't really see that. And I think there are some additional actions that are now being taken. So the County Council and CCG are reserving, or have now reserved, block beds in nursing homes that we can use to transfer patients who are still in hospital awaiting pathway 1 home with care or community beds that aren't available, so that they can go through there before going on to their preferred location for care if we can't get them out of the hospital. And we've also had some beds now booked in one nursing home that become operational tomorrow, which is for nursing home residents who were admitted to hospital and are positive, because it's become a challenge to get them back to their initial nursing home. So we've got a block of beds in one single nursing home that we can use for that cohort of patients. But I think from my perspective, I'm in the same position as you, Bill. We need strong public messages to maintain social distancing. Enjoy Christmas, but don't take risks, because the consequence could be quite significant, and that would probably fall through at about the last week of January. So if what I said is correct, that we don't see any loosening of the position until mid to late January's at the moment, based on the flow through from the reduction of prevalence in the community, we could get to that point and then it jumps straight back up again, so we get no respite.
Okay, thank you for that. Julie.
Thank you. Bill's asked some of my questions, but Paul, I wanted to just ask about 111, because while it's really, I agree with the others, it's a better plan than we've seen, and the whole health system seems to be working together better. How is that being audited and fed back about 111, and what's being taken to improve it? Because that is a disappointing part of this.
Yeah. So there's a 111 steering group that contains all system stakeholders, and that meets on a fortnightly basis, and that's where the review is undertaken, and then that feeds back and reports to the A&E delivery board, and that the issue for us at the moment is waiting to see the concrete data that either supports the clinical view that what we're seeing is an increased prevalence, not a reduction in presentation in ED. And as I said, the data that we need has been delayed. We haven't had it. I don't, from my own observations, I don't believe that data is going to demonstrate, which is an increase, not a decrease in presentation.
Okay, Matthew.
Thank you, Chair. So a couple of comments which sort of play into some of the points that colleagues on the board have already referred to. First up, though, I'd like to thank and commend Paul for his leadership through this period. I mean, the point, Julie, that you make around the evidence system working, I think, is clear, and certainly at chief operating officer level and through the arrangements within the system, that the sense of collegiate working and focus on putting patients first has certainly spread out from our organisation across the county, and Paul's played a huge role in that, and particularly as Gold Commander on COVID, I think managing the phase 3 return of elective and diagnostic services, the COVID challenge, and the reasonably good performance on 4-hour standard is no mean feat. So I wanted to just make that note, Chair, if I may. The other points, I think what Paul hasn't alluded to is yesterday afternoon we had a regional assurance meeting with NHS Midlands to take a view on our plan, and there were some clear concerns from the region about 111 and also the 2-hour response, and the region took away a number of actions in relation to working through with the ambulance service how they're able to better implement their change management with their paramedic crews to make sure that patients are being taken to the right place. So I think that should give us at least a sense of the region supporting our plan. I think the other thing that Paul hasn't talked about, which I think is going to prove quite important for us, is that we have established a lead manager across the system for intermediate care, and the director of people at the county council, Sarah Dugan at the Health and Care Trust, and myself have essentially given this individual the power to hold to account anybody that is slowing down discharge of patients into intermediate care. And whilst 94% of our patients that are discharged, those that Paul alluded to earlier, are simple discharges that don't need follow-up from community or being put on a social care pathway. There have, as you know, been significant delays in the past, and we've established this role on an interim basis with a view to making it permanent once we can evaluate the impact of that. And I think that's an additional level of mitigation, Richard, that isn't referenced in the winter plan. That's come subsequent to that. I think the other key things that I think we do need to do is we need to refresh the capacity and demand analysis based on the numbers that Paul has shared this morning, and that's been agreed to be taken forward by the CCG. We also need to see what is the impact so far of the schemes that were articulated in the waterfall. And when our system leaders met on Tuesday, we now meet every week to review progress with the winter plan. We demanded next week to see progress against those schemes so that we can see actual against the plan, which we haven't necessarily seen before. And I'll be looking to review that properly at the A&E delivery board. So I think the view from the region is that we're holding up better than most, but we're not being complacent given the discussions around COVID and the fact that we don't believe yet that we're at peak. And I think the other key point I would make is that there is a huge risk that people will become complacent now there is a vaccine, and I think that's as big a risk of increasing rates in the community than perhaps even Christmas is. So I'll pause there, Chair. Happy to take any questions on anything I've referenced.
Okay, thanks. I mean, I think that nobody faced with this plan and this challenge could say that it's all straightforward and that this plan is completely robust. It isn't. And I completely take your point, Matthew, about we need to continuously rejig these numbers in the light of our experience, particularly around COVID. But if anything like what Paul described, i.e. a doubling of the bed-based problems actually materialise, the whole healthcare system is in serious trouble. And I'm not sure whether we yet have got a sufficiently robust contingency here for dealing with our element of that. Now, I know it's not possible, you know, I understand how difficult it is and all the rest of it, but I think what we've learned from the past in all of this, particularly in relation to this hospital, is that hoping for the best seldom actually delivers the reality. So we do really need to think more carefully about all of this, and we need to absolutely crystallise this. I mean, for example, one of the things I know that we've identified as a particular importance is getting patients out of the corridors. Now, I don't know what the implications of all of this is for corridor care, for example. And what we do know is that most of the consequences of all of this going wrong will obviously be faced by the patients themselves and their families, but also this organisation, because we will end up with all of those patients waiting outside of our. So the incentive for us to get it right is important. So I would like to see a refreshing of the numbers so we can get a proper handle on it. I think we need to think a bit more carefully about what our contingencies are, if anything like what Paul described actually happens in practice. And I commend the work that people are doing across the system to enable this to happen, because this is going to be a very tough time. I mean, and we'll use every opportunity we can to get the message out ourselves about behaviour of the population and how we can advise the population in the right way. Nobody in Worcestershire wants the healthcare system to be overwhelmed in January and February, but it is perfectly possible in the circumstances that have been described to us today. We'll work with the local authority and public health to get that right. And this whole idea is just because you can do something doesn't mean you should. Over Christmas, I think, is an important thing for us. Okay. Any other points that people want to raise about that? But obviously, Matthew, keep up the work to make it happen. And just to add my thanks to the efforts of Paul Brennan, the Chief Operating Officer, who is doing an absolutely remarkable job to keep all of this in some kind of order. Thank you for that, Paul. Okay, so in terms of the plan itself, we I've explained, I think, what we need to do going forward. There's nothing else that we need to do in relation to the plan at the moment. No? Okay, thank you. Let's then move on to the integrated performance report. And is on Matthew going to talk this, or is Vicky going to lead us on this? Vicky?
Thank you, Chair. Yes, so this is the integrated. Thank you. So the integrated performance report for October, so month 7 for us. It's been through the Trust Management Executive, and it's also been through the Finance and Performance Committee and the Quality Governance Committee. You will note that we've actually included the assurance statements as part of the pack, the appendices in the pack, to give some clarity. And all of the statements as we go through the report have got an assurance level applied to them. With the only one showing at an assurance level 2 of the sepsis 6 bundle. All of the others are 4 and above. There are 4 key areas of challenge that have been identified by the executive team and TME. One is what we've just discussed at some length, which is the wave 2 of COVID on the elective active recovery plan. Maintaining high quality care, so picking up very much what we talked about last month in terms of infection prevention control and those measures. And also now we've completed all of the environmental risk assessment on our wards and department areas, which is incredibly important given we've talked about the fluidity of the changing position around COVID and how we're flexing and dealing with our bed base around that to ensure patient safety. Demonstrating wellbeing for our staff. So we talked at length last month about some of those measures that we've put in place, so the buddy system, and also about that 24 staff helpline for just supporting people during this unprecedented time and making sure that we care and cherish our colleagues. And then the financial position for the organisation. So month 7 saw that change away from the month 1 to 6 financial regime, which was put in place with a break-even position, to the position being reflective of the phase 3 activity, which shows us actually in a positive position at month 7, I think, of about £2 million for the good against the actual plan. I'm sure Robert will talk at some length about that. And that's all really I wanted to say, if that's okay, Mr. Chairman. I'm sure Matthew and other exec director colleagues will want to chip in. Thank you.
Yes, Matthew.
Yeah, thanks, Chair. So I wonder if we should go straight to the conversation that we need to have around sepsis. given that, as Vicky says, the assurance level stands out compared to other areas of the integrated performance report. So if that's okay, Chair, if I ask Mike to make some comment in relation to that.
Mike.
Yeah. So I think it remains a challenge. So we've implemented a new electronic training system. Mike McAlinden, who's the lead, is doing a significant piece of work to look at it. I've met with our chief registrar to discuss what the issues are from the doctor's point of view. The feeling is that a lot of the time this is recorded in the notes but not on the form. So we've initiated a quality improvement programme with her and a number of junior doctors to look at that. And I suspect coming out of that will be a change so that instead of using the form to record something that is, as far as the juniors are concerned, irrelevant, it becomes their recording of events that gets filed in the notes, whereas at the moment it doesn't and disappears off and they don't regard it as relevant. So the snapshot audits that have been done suggest that actually activity is not as bad as it appears from what we're recording. The only thing I would say is that from an assurance point of view in terms of the impact on patients, we do know that our outcomes for sepsis are not out of kilter with the national numbers, but clearly we need to get the reporting on this aspect of it more focused and sorted out better. So the plan would be to bring back a detailed response in the new year when that work has been progressed and we've got more data on it. I'm happy to take any questions.
Any points on that? Yes, Bill.
Thank you, Sir David, and thank you, Mike. Just really to emphasise the fact that the Quality Governance Committee does have this absolutely in its crosswires. It has been one of the wicked issues that hasn't moved sufficiently in our view. Working with Mike very closely, we are looking forward to receiving a deep dive report in January when these actions will have been instigated, and I hope we'll be able to come back with greater assurance at that point.
Okay, thanks. Can I just, Mike, just so that we understand completely the point that you're making here. The first of all, you're saying that our outcomes in relation to patients with sepsis are good, bad, average. What are they?
Average. They're average. They're not where I'd want them to be, but they're not out of kilter with national numbers. So
okay.
I think we've got two separate issues. Are we doing everything we could? Well, the answer is we don't know because we're not recording it effectively.
Yeah.
Are our outcomes acceptable at the moment? Yes, they are. Are they what I would aspire to see us deliver? No, I don't think so. They're just above 100. So we're in the funnel plot, but I'd like to see us below 100, obviously.
Okay.
I think some of this is reflective of people's perception that this is a box-ticking exercise as opposed to actually demonstrating the quality of care we're giving. And I think that's the work that Sarah Packer and I are doing around engagement with the juniors that will probably change some of the data recording, because this is all recording by junior medical staff. And if we can get them to see the value of it, I think we'll get a better understanding. And that will enable us to target the bits that we're not really delivering on, as opposed to the perception that you get from most of the clinical staff at the moment. Well, we are doing it, we're just not writing it. We've got to get that culture change. So hopefully the work with the juniors will help.
And presumably we've been looking at the implications of the recent report into the death at Dudley.
Yes. Absolutely.
Okay. Well, we need to get this. We need to get this right. obviously, as you know as well as I do, recording is an important part of the clinical process as well as actually hands-on patients. So let's get all of this absolutely right. Recognise that your comment about the current level of service is acceptable. Well, we'll let QGC to have a look at that in a bit more detail and assure us whether that is, I'm sure, whether it's in the right sort of place. But increasingly, we need to get this action done and improved, because we don't want to go on as a board considering this as a set of issues. So let's hope for the next board meeting we've got some real progress to report. Okay, thanks for that. Can I just, in terms of your report, Vicky and Matthew, there's you've raised 3 areas that we need to identify, that we need to talk about. Actually, there are 4, aren't there? One of them is the impact of COVID-19 on elective activity. What's happening there?
Yeah, thanks, Chairman. So if I can ask if Paul's still there, he is. You can see some of the graphs show that there is recovery in some of our cancer performance, but this remains a real challenge, particularly given Paul's reference to the 260 beds and the need to be very mindful of not allowing waiting times to drift further than they did in phase 1. So I think this is hence why it's one of the top 4 things that we're concerned with. So Paul, do you want to just make any quick observations, then happy to take any questions from colleagues in relation to that.
Yeah, sure. So in terms of just kind of running round the key areas, then in relation to cancer, we've seen a significant reduction in the 104-day waiters on the 62-day pathway, that rose rapidly during the first phase to a high of 186, and the end position for month 7, October, was 44. We've also seen a continued reduction in those patients waiting over 62 days, which hit a high of 262, and at the end of October is 185. So that's positive, but there's still a lot to do, as our objective is to get the number of patients over 62 and over 104 to 0. I mean, the reality is, because of the nature of some of the treatments, there will always be a few patients that make it the 62-day level, but we should not have anyone waiting over 104 days. And as I said, we've got that down to 44, and my expectation is that it will be lower than that at the end of November, month 8, but that's not reported yet. In terms of diagnostic performance, then colleagues will be aware that we had to submit a phase 3 plan, and at the end of November, which is the first 3 months of the phase 3 plan that runs from September to March, our diagnostic activity, both endoscopy, MRI and CT, is above the submitted phase 3 plan, so we're overachieving. In terms of elective activity, the combined inpatient and day case, again at the end of November after the first 3 months, is above the phase 3 plan, so that is also overachieving. But outpatients is under the phase 3 plan and is running about 11% below the plan that we submitted. And that's been for a number of reasons. That the below plan is both face-to-face and virtual appointments, and we have suffered more than we anticipated with social distancing on the face-to-face appointments, that has led to less throughput than we forecast we could achieve in the face-to-face. And secondly, for a variety of reasons, we've had to use outpatient accommodation for clinicians to do some of the virtual consultations, and therefore that has also limited our capacity. So I think the area of most concern is that before the pandemic, the number of patients waiting over 52 weeks was 0, and at the end of October that stands at 2007. We are doing harm reviews on all patients, and that we've not identified clear harm yet, but I feel that with that number of patients waiting that length of time, there is a real risk within that. And I think within that group of patients, one of the areas that we have to keep on top on is those patients who have been waiting a long time for their first outpatient appointment, and continuing to review that because we haven't seen them. So in some ways we don't necessarily know the level of risk, though clearly we have the GP referral, and we have now put in the complete referral system that we've been discussing with the primary care clinical directors, and that's working effectively. We are achieving the turnaround standards that we set with GP colleagues, and in the discussion last week with GP colleagues, they reported their view across primary care that what we've implemented from their perspective and their patients' perspective is a resounding success. We're getting where we've identified that patients need to see us, we're feeding that right back to GPs, and where we are identifying actually that we can give a plan for GP colleagues to implement, and therefore patients don't need to come to secondary care, that is being well received, and there has not been any issues raised on either the acceptance of the referral or the provision of a plan for the patient to be managed in primary care. So I think the big risk area remains the number of patients waiting over 52 weeks, but we are doing the clinical triage and harm review, and clearly our desire to get the 104-day cancer patients down to nil. Those are the two areas that, from my perspective, are where we're concentrating.
Are we using the independent sector and the Kidderminster Hospital to full effect?
So in terms of the Kidderminster, we are using 3 of the 4 operating theatres. Colleagues will be aware that we relocated the chemotherapy unit to Kidderminster from the Alex as part of the first wave, and that we are developing a new facility on the Kidderminster site for the chemotherapy unit in A block, and that will become operational on the 15th of January. We will then move the chemotherapy into there out of the theatre area, and that will mean we'll bring on the 4th theatre. So we're running 3 out of 4 theatres at the moment, and we'll be doing 4 out of 4 from the 15th of January. In terms of the independent sector, yes, we are still using the independent sector. To date, at the end of November, we've done 2,116 operations across Spire, South Bank, BMI, Droitwich and Dolan Park, and we've undertaken 1,057 endoscopy procedures. So that means that we've seen over 3,200 patients in the independent sector since we started collaborative working with them, and we're just trying to negotiate continued use of the facility because the national contract is due to close on the 21st of December, but new guidance was suddenly issued this week that gives an indication that we could potentially continue to use the capacity until the end of March. we had already taken our own initiative in relation to Dolan Park and had contracted with them to the end of March to secure that facility. And we've had good discussions with colleagues at BMI Droitwich to secure access prior to this issue that's come out this week nationally to the end of March. And we're in calls with colleagues at Spire South Bank this week. And we're just working through the document because it only came out on Tuesday, the implications of that.
Okay, thanks, Paul. I've got Bill and Richard. Bill, first of all.
Thank you, Sir David. Again, Paul, congratulations on all the hard work. It's an incredible piece of work you're doing and doing so well. I am a little concerned around the outpatient performance, particularly our failure to convert face-to-face consultations to virtual consultations. I'm just wondering whether that's something that we can examine and explore a little further. Did we just make were our estimates wrong, or have we got reluctance from any groups to actually perform virtual clinics? They seem to be successful elsewhere, so other hospitals have done quite well with virtual clinics, and I just want to make sure that we are truly putting our patients first and our clinicians are doing what they're being asked to do, even if it's less comfortable for them, which I clearly do understand.
Yeah, so we've had some issues in that, so we've got some colleagues who are working from home, and we've lined up to do face-to-face clinics. I have to say, Mike may be able to help me here. It's not really my territory, but there was some governance issues around using your home phone for doing patient consultations. So we have to get a whole load of mobile phones to enable that to happen. And we hadn't, or should I say, I hadn't predicted that. I hadn't realised that. Secondly, one of the things that and I think it's a positive, it just doesn't fall through on the numbers, is that after we'd submitted the plan, there was a lot of working with the ophthalmology team, and they shifted a significant amount of outpatient capacity from consultant-led to nurse-led clinics. We'd included that capacity in the submission because it was consultant-led at the time, and we're not allowed to report nurse-led. So that's the second factor. Third factor is there was a mistake in two of the specialties, 2 out of the 42, where an overestimate of the amount of activity that we could deliver was made. And then, as I said earlier, the other issues were the impact on throughput of social distancing and the need to use some outpatient accommodation for virtual clinics so that the clinicians had confidential space to be able to conduct those virtual clinics wasn't sufficiently robustly factored into the calculations. What we are doing a significant amount of virtual clinics, but those we haven't picked up the issue about the phone.
Okay, Richard.
Thank you. So first of all, Paul, I wanted to repeat the compliments that Bill gave. I think we are making really good progress in 3 particular areas: length of stay and long length of stay. I think it's really positive to note. The ED performance, which we were really concerned about, which is stabilized and even slightly improved in the circumstances. And the amount of elective work we are still able to do despite the COVID situation. So I think that's all really positive. I had 2 concern areas. One was the one that Bill already asked, so I'm not going to repeat Bill's question. The second one is around the long waiting lists. You've talked a little bit about it in terms of the harm reviews and the people who haven't received diagnostics. My question is, do you feel we're doing enough there to really manage those risks? Because the waiting list is increasing so quickly.
Yeah, I mean, I think that the overall waiting list has gone up. Pre-pandemic, we were bringing it down, and at the end of March, that waiting list stood at just over 35,000. And as you can see, the position at the end of October is just over 41,300. So the total number's gone up. And then, as I said, we've gone from 0 to 2007 on the 52 week. We are doing the harm reviews, we are doing the clinical triage, but the capacity that we have available to us is heavily focused on undertaking the Category 2 and Category 3 work. So we have limited capacity to do the Category 4 work, and that is where the majority of the long waiters sit, and that is a challenge for us. As I said earlier, at the moment we're running 3 out of 4 theatres at Kidderminster. We're running regularly, we're running 4 out of 6 theatres at the Alex. Sometimes we get to 5, and we're running 5 theatres here at Worcester out of 8, although pre-pandemic we were actually only using 7 theatres, as 1 theatre has been closed for a number of years. So we are down on our theatre capacity across each of the 3 sites, and we are limited to 2 wards. As I mentioned in the beginning when I was saying the COVID pathways, we only have access to 1 ward at the Alex and 1 ward at Worcester for undertaking green elective surgery. So I'm sorry, I mean that sounds a bit more like an excuse than an answer, Richard, but it's, you know, that's the challenge we have, and we have focused the resource that we have available to us on the cancer and Cat 2-3 patients.
Well, that was basically my question, Paul. It's about how do we prioritize on the high-risk cases? I think you've answered.
Yeah.
But also, I guess, what are the limiting factors? Is it operating theatre availability? Is it staff? Is it beds? You know, what is the limiting factor that's stopping us, in a sense, doing what most other hospitals seem to be able to do, which is keep their elective activity up at levels that don't result in a massive increase in their waiting list? That's the issue.
Well, I think that looking at the national position, the overall number of patients waiting has proportionately increased nationally, greater than our waiting list has increased. The challenges are that we faced is beds, because, as I said, we've only got 2 wards functioning for elective green surgery. Theatre capacity, because again, it's at any one time we're between 5 and 3 theatres down on what we were pre-pandemic, and because of all the IPC requirements, the productivity through our theatres is less than it was pre-pandemic. And colleagues will recall that pre-pandemic we were actually being challenged that our theatre productivity was not at the level it should be anyway.
Well, I think, sorry, I've got Colin who wants to say something, and then we'll move on to the next one. Colin.
Thanks.
Colin?
Yeah, there's reference in the documents about the installation of the 3rd CT scanner, and we're waiting resources for the STP, the radiographers. I wondered how that was getting on, because presumably that's quite important to get that sorted.
Yeah, so the 3rd CT scanner, so we've been given resource to provide a 3rd scanner, and in the first instance we don't need any additional staffing because we have to replace CT1 and CT2 at Worcester, and we also have to replace the CT scanner CT1 at the Alex. So we've got the resource for implementing an additional CT scanner on the Worcester site, and then that will be used to decant the scanners whilst they're replacing. So we're still working about revenue resource to ultimately fund the full running of the third scanner, because we're targeting July, it should become additional capacity. But for the first 7 months, it's a decant capacity as we replace the other existing scanners. What we have done is, at the moment, we have a mobile scanner that's funded externally at Kidderminster that is functioning 5 days a week, and that is fully staffed. And we're hoping to maintain that till the end of March. The only risk to maintaining access to that is if the Nightingale Hospital was to reopen. And then secondly, working with colleagues in the regional team, we've been able to source a second mobile CT scanner that is fully funded externally and staffed, that we could have for the equivalent of 1 week a fortnight, and we're looking to bring that into the Alex before Christmas to increase CT capacity.
Colin, does that answer your question?
I think so, Chairman. My question was really about whether this was a critical obstacle, or the lack of resources was an obstacle towards increasing capacity and addressing the issue that you were raising. And I think Paul said it isn't an issue at the moment, so I'm satisfied with that.
No, it's not an issue.
Okay, let's move on then. Matthew, any other issues in relation to the paper that you want to draw our attention to?
Yeah, thanks, Chair. I think the other key thing that I think we really should spend a couple of moments on is the point about infection control that's in the report. And I wonder if I can look to Vicky just to provide us with assurance that there is the right degree of focus. And perhaps Bill might comment as well on the discussions that we had at QGC.
Yes, thank you, Matthew. I think the key part here that is brought out in the narrative around MSSA and carbapenem usage is really important for us to be able to focus on. And Mike and I had a discussion last week about actually what we could stand down in terms of during COVID, the complexity that we're dealing with in terms of outbreaks, and making sure that we've got to focus on the prospective actions that we should be taking to make sure that we drive down on the actions that we've identified along with Bill and QGC that we need to drive through, because the importance is clinicians at the front line endorsing all of the actions and undertaking those so that we can see the improvement, because we can't wait for COVID to be over and finished with before we refocus on those areas. So the focus is absolutely there, supported by an agreed position in terms of all of the meetings that we stand down to free staff up to make sure their focus is on the safety of patients here and now and focused on those areas that are highlighted in the narrative. But I'm happy to take any questions on that. But our focus absolutely and centre two has been on managing the safe management of the outbreaks across at the Alex and at Worcester, which obviously adds to what Paul was saying earlier on.
Okay, thanks. Any comments in relation to that? No? Okay, Matthew, what else?
So thank you, Chair. I think the other key element is clearly staff welfare and the staff offer, and clearly we're starting to see in some of the indicators prior to the main wave 2 hitting us. Obviously this is October's report. Some of those people indicators are progressing well. So Tina, I don't know whether you want to just draw attention to where we are in relation to some of the key indicators where we are in terms of flu vaccination. And Chair, if I may be so bold, I wonder if we ought to touch on the vaccination of the COVID vaccination situation as well, which perhaps also Tina might be able to cover with full support.
Thank you.
Yes, very good.
A couple of highlights, if I may. So absence in general, staff absence has been increasing since October due to mainly to the second wave, because that's not just a sickness absence, but for shielding, social distancing and etc. Some of the things that we've been proactively undertaking to improve our absence rates, which has had a positive impact, and we benchmark well against our peer group, and particularly within the Midlands. But that's with the caveat that we've not been as hard hit as some of the trusts within the Midlands with regards to the wave 2. Our absence for stress, depression and anxiety, so mental health related absence, has remained consistent and is at our normal run rates prior to COVID. And so we've done a lot of interventions around the mental health first aid training. We've also put in some support for teams through our health psychology, and we've got the 24-hour counselling service. We've also, through Vicky's team, introduced the lateral flow tests, so the tests at home for colleagues twice a week, and we've identified over 30 people that were asymptomatic as a result of that, which also helps with the reduction in the spread of infections amongst staff colleagues. Also, when the second lockdown, we had approximately 150 people that were in the extremely clinical vulnerable group. About 70 of those we were able to support to continue to work from home. The 81 that couldn't do that, we were obviously working with them to redeploy them within the trust or in the system where we could. And since the lockdown ended, we've now only got 7 of those staff not able to work, and so we're just awaiting further support from occupational health on those 7. But to me, that's a really good proactive piece of work. So we undertook refreshed occupational health risk assessments for those individuals and kept regular contact with them, and actively sought a redeployment for that group. On the flu vaccine, our latest figure is 76%, but we have undertaken the flu vaccines alongside the collection of the lateral flow tests, the home tests, and that's proven to be a really good way of increasing our figures. So we jumped 30% in a week by doing that, because of 2 issues. One is a set of data was put in the internal posts. There's been some delays, and also a data warehouse issue. I've not been able to get the latest figure for today's board meeting, but I will circulate that once that arrives through later today. But so we're at least 76%, and we're aiming for 90% by the end of this month. And the HR business partners have got a list of all those staff that haven't had the vaccine yet, and they're working through those as we speak with the divisions to make sure the flu champions work to improve those figures. And finally, the COVID vaccine. We've anticipating the delivery of the vaccine to start on Saturday, and we've gone out to a booking system for staff across the health and care sector, and all 600 slots for Saturday, Sunday and Monday are, I believe, Paul, taken up now and full. And so we're planning basically for the first 5 days of the vaccine. That's all we can say probably at the moment, isn't it?
Yes, that's correct. We're expecting the sign off in about 3 minutes' time for the order of the vaccine, and then for it to be delivered sometime tomorrow. We will start the vaccine at 8:30 on Saturday morning. As you say, run for 5 days, and we're expecting, providing that everyone turns up, and we have reminded staff that it's essential, having booked in, that they turn up, and if for some reason they can't, then they need to cancel on the system so we can reallocate the space. We can't afford any, if you like, do not attends, and that we don't have any wastage. Then we expect to vaccinate 975 members of staff across our hospitals and the Health and Care Trust by 8 o'clock on Wednesday.
Okay, that's very, very good and very important, of course, the work that people are doing on the vaccine. So thanks for all that, Paul and Tina and the rest of the team. I've got a question from Mark.
Thank you, Chairman. I wanted to return to flu vaccine to get a better understanding, because we had a 75% uptake on December the 1st. We're now on December the 10th, and we're at 76. So could you say when that figure was? I appreciate you said there's been some lag because of some internal issues over figures. So when was that 76? I'm concerned that in 10 days, we've only moved 1%. And secondly, our original plan was to have 90% rolled out by week commencing 14th of December. So within a week, we were due to be 90% according to our plan. So what hasn't happened for us not to be able to hit that 90% mark by next week, in essence? Thank you, Chair.
Thank you, Mark. So we've undertaken all the actions that we said we would. So we've increased the number of collection points for the lateral flow tests and been given vaccines at the same time. The issue is that I can't report an accurate figure today because of the two issues that I mentioned earlier. So the 76% is the day after the People and Culture Committee, so last Wednesday. So we've still got a week's lag of figures to go in. And the business partners have been proactive since within the divisions to chase up those that were still outstanding. It's just that I can't confirm in a public board the accurate figure, I'm afraid.
Yeah. Okay. Well, keep up the good work, Tina. It's really important that we get that right. Matthew told me the good news that we've moved 30% in a relatively short amount of time. My response to him was, that would be great if it was from 60% to 90%. So unrelenting our focus on this to get this right. It's really important for our patients and for our staff to get this right. And good luck and all the rest of it. On the vaccine, great work, I think, that's been done, all of that. I know there are kind of frustrations around being able to communicate a lot of this stuff publicly and all the rest of it because of the way the national team hold on to all of this, but you know, I think people are doing a fantastic job to make it right. Okay, and well done everybody for that. Okay, shall we just have a conversation about the financial position, Matthew?
Yeah, absolutely. I was hoping you'd give me another chance to cover the fourth slot, which is our financial position to the end of October. Robert, over to you for headlines, and I'm sure that Paul and Tina particularly will add any comments around the impact from a workforce perspective. So, Robert.
Thank you very much, Matthew, Chairman. I think, as you can see, we've moved just to remind ourselves that for the first 6 months, whatever the financial position was, the trust would be moved to a break-even position at month 7. That has changed for months 7 to 12. There's an allocation that's been applied to the total Hereford and Worcestershire STP, of which there's been agreement among us as to how that is split, and against the money that we received or were planned to receive in October, we actually were slightly underspent by a couple of £1 million. The reason that there's that positive variance is very much, as Paul has already mentioned, is whilst in the main our activity remained as we expected and planned for month 3, what we didn't have was the number of beds that were expected to be open. So we had a positive variance against that. I think that's the key point that we've got. The other thing there is clearly we are challenged in being able to access significant numbers of the bank and agency staff that we've had previously. But I think in the main, that's the reason that we're a positive variance to plan. The concern, of course, is moving into the future. What does that mean, as we've just had the discussion on our wait lists and long waiters, and making sure that actually we can address that certainly into next year. I'm not sure that there's anything else really that I'd want to bring forward at this stage, Matthew, if that's all right.
Okay, anything, Richard, you want to add to that?
I think Robert has addressed the main points. We were positive about the controls in place on bank and agency, and you can see some of that back in the figures. The concerns Robert raised, we have as well. There's been a focus on cost more than on income, clearly, given the current situation. I'd like to note the fact that there's more detail on the capital plan, and that's really important because we've got a lot to spend, and maybe we don't have the complete ability to execute on this. So it's important we look into the details of this. Other than that, we have had extensive discussion on how to focus our efforts on next year and thinking about the bigger changes to our financial position in next year.
Okay. Thanks. Any other points? There's a letter that's gone around. I received it from Simon Trickett's about the finance subcommittee and about a commitment that we've made to develop a balanced position across the whole of Herefordshire and Worcestershire. Do you want to say anything about that, Robert?
Yes, Chairman. Yeah, I think that's a really good point. I think we've been having discussion. I think there's an element of, given certainly ourselves and Y Valley as the other main provider, we're clearly showing similar levels of not being able to open up the beds and therefore not spending on, as I said, the additional staffing. What we've seen there is this is, whilst it's a financial advantage to what we've been expecting, it's not the advantage we'd want in terms of our ability to treat the patients, again, as we've just discussed. So we haven't had the full capacity, certainly as Paul mentions, on the beds to be able to do all of the work ourselves. It's clear that is partly a planning variance, but it's mainly the impact, I think, in the last 4 to 6 weeks in particular of the second wave of COVID. As such, I think it's more of a sensible discussion to take a view that says, if you're looking at this, and the early position for November is not a dissimilar level of difference in terms of the funding we were expected to be needed to be committed to where we are actually at, that we've got another 4 months to go. So I think, as opposed to a firm commitment, what we said, it was likely, and I think Colin, who was at the forum with me, would confirm, I said this was likely that this would continue through the winter. And the concern I had wasn't so much about the money, Chairman. It was more about actually how we're able to make sure we can deliver what we need for our patients, both in the next 4 months, but more particularly then as we come out, hopefully, of the winter, how we're going to do that into next year. So the key point of discussion was as much, actually, we need to make sure we've got the resources to be able to the activity within the right money next year, and getting that planning position right, as opposed to saying, well, you know, we're still way out in terms of this year's allocation, if that makes sense.
Okay, do you want to add anything to it, Colin?
The only thing to add really is to question Robert as to whether or not the message got through to your satisfaction to the centre, so to speak, because you encapsulated the discussion absolutely. We did say this wasn't as a result of a series of interventions that had enabled us to reduce our expenditure. It was a function of our capacity, and it wasn't something that we necessarily desired. And I think we agreed that we would ensure that message got through to the centre. So I just want assurance, really, that at a regional level they're aware that whilst we said we would do our best, this wasn't an absolute commitment.
I think in terms of has that got through, or was that the way it was presented, possibly not as black and white as that, but we are having a quarterly review with the region tomorrow with a pre-meet tonight, Colin. So I think we will just re-emphasise I think the more appropriate phraseology might be the right way to put it, yeah, or a clearer phraseology, sorry.
Richard.
Yeah, I was going to emphasize what Colin has said and make the reference to the phase 3 recovery plan, because we're not going to meet those numbers and be in that financial position.
Yeah.
Yeah, this is an issue that's not consequence free, is it? And there are a couple of things. Well, the first thing is that I just want to make sure that we're not keeping two sets of books here, that we're measuring ourselves against things that we've already committed we're not going to deliver. That's all, in financial terms. So we just need to make sure that there is one set of books that we all understand, and we're monitoring the financial position on what we've committed to be the outturn. The second issue, I think, is about the consequences of that is not being able to as rapidly, even if we had the capacity, to build up the elective capacity. And I think then that needs to be really clearly understood, I think, by everybody, that if they do want at some stages to increase that capacity, then we have to change the way in which we've made that commitment. I think that's fine. And we'll have the opportunity to speak to the region on Friday when we have our discussion with them. Okay, thank you very much. Anything more on that? No? Can I very quickly then move on to the committee assurance reports? Are there, so if I do them one by one, we'll have covered a number of, and I notice in the reports there's nothing that's been specifically referred to us. But finance and performance?
All's covered, David.
Yeah, thank you. Reassure that. Quality governance?
I think we've covered the most important things, David. Yeah,
okay, thank you. Was that the only ones? Oh, people and culture, sorry.
Yeah, it's all been discussed, the important bits, David. Thank you.
Okay, very good. Well, thank you for all of that. Let's then move on to the Audit and Assurance Committee report. Steve.
Thank you, David.
Your swan song. You can sing us a song or something.
It'll be a very short one because I'm not a great singer.
Okay.
The only item we wanted to bring forward was really looking at how we develop our governance and assurance systems in response to the development of the ICS. But we're going to cover that at the next meeting, so I won't dwell on that now.
Yeah. Okay. Any other questions or comments? Thank you, Steve. Succinct as ever. Thank you. Right then. Any other business? We didn't have any. That is the end of the meeting. I'm very conscious that our colleague from Health Watch has been here. Just trying to find her. Joe?
Yeah, I'm here.
I don't know, are there any questions you want to ask or any points you want to raise in relation to any of that?
I just have a couple of things. One is I think the Access Able initiative is fantastic and really appreciate that.
Yeah.
With regard to the winter plan and the resilience and everything, we're very aware of the huge amount of work that's going on and very pleased by the amount of system collaboration that we see when we attend all these meetings. It's nice that some of the initiatives are already delivering in a way that they haven't in previous years, like the length of stay. It's kind of nerve-wracking sitting here as a member, somebody who's not an expert in any of this. And it's just, I suppose, how assured you really are about your winter plan delivering. I mean, it comes across you're working really hard and you've got all these things, and it would be really nice to see the waterfall chart with the enhanced ambulatory care and how it's all going to, have the sort of the forecast rather than the original model, I think. And I suppose the other point I wanted to make, or not a point so much, was when you're looking at your waiting lists and you're doing the harm reviews, do you also talk to the patients? Do you communicate with them and then let them know what's happening with the waiting list? Because it's very anxiety-making for patients if they're sitting, on a waiting list and nobody's telling them what's happening. It really does increase the anxiety and the sort of the health and well-being issues. Thank you.
Okay, thanks. Can we just deal with that particular issue first, then I'll respond to the other two.
So if it helps, Chairman, as part of a national programme, we have written to all of our patients who are on our waiting list at the time when we did the snapshot in October. This is patients who are waiting for surgery, so they're on our elective surgical waiting list. There was just over 10,000 of those patients, which form part of the 41,000 overall waiting list I referred to earlier in the meeting. We have written to all of those patients. I've written saying that they will receive a call from us and that we will speak to all of the patients by the 31st of December. The last update I did, we had spoken to around about 7,500. That was at the end of November. This is an initial administrative contact, so to check the patient, they're still there, they still want their procedure, and any issues they want to raise. We have a script for doing that, and then if there are any concerns, the patient is then spoken to by a member of the clinical team, and we expect to complete that work as planned by the 31st of December.
Thank you.
Yeah, I mean, in relation to your point about the winter plan, I think you're not alone to sit there being slightly nervous and worried. I think we're all nervous and worried about the plan, because there are a lot of imponderables about it and lots of pressures on us, as you know. I think you're right that we need to reformulate it based on the latest information that we have, and we will do that. And we have to really identify all the risks in delivery and then try our best over the next 2 or 3 weeks to put plans into place to mitigate those risks. We're not going to get rid of the risks. You know, COVID is still going to be there. There's still going to be respiratory disease and all the rest of it. But I think we can mitigate quite a lot of them. But so thanks for those comments, Joe.
Thanks.
Right then. Okay,
and sorry, Joe, if I can just add, Joe, if you're at next week's A&E delivery board, please make exactly the same points as you've made, because I think framing that message in the way that you have done will be helpful to challenge everybody around the table as to get their response clear and their level of assurance explored as well. So thanks for that comment. Thanks, Joe.
Thanks.
Yeah, thanks, Joe. Okay, well, that's the end of the meeting. Thank you very much for all of that. Kamara, we're going into a private meeting. Are we going to have a rest now? Is there a gap?
Yes, Chairman. There is a gap.